So thank you all for taking the time to come here. And also would like to thank Dr. Foote and the COK, the research office, to provide this opportunity for us to give you this introduction to our service. So the biostatistics and study design. So first, just the basics. So who we serve. So if you are a UA College of Medicine Phoenix faculty in any category, affiliate, adjunct, any category, we can help you. Also, I understand that sometimes it could be slow for them to process those faculty applications. So as long as you are already in the process of obtaining a faculty status with the College of Medicine, we are able to help you. Also, we also help provide statistical support for students in their scholarly projects. There's no charge for statistical service if your research is unfunded. Also, if you are applying for grants. So I'll mention if you're applying for external grant, we'll probably get a piece of that grant. But if your research is unfunded, there's absolutely no charge. So we understand, to get grant, you need data, preliminary data. Also, you need probably a lot of publications. So there's no charge. Here's our website. I hope COK has already sent the website to you. So for our talk, my talk, and also Dr. Foote's talk later, we'll post all slides on the website. So you can, this is connected. Okay, good. So this is our website. So you most of the information are already there, and here under the education tab, we'll post all our talks. So later on, I imagine throughout the year, we'll provide some kind of tutorials on data management and so on. So we'll provide certain tutorials. We'll post all those slides here. So our slides for today will be, you will be able to find them here. So that's our website. So contact information. So here, if you are a faculty, if your research project is not a scholarly project of a student, we ask you to contact us through this online intake form. It's not supposed to be a barrier. So the form is all very easy. So as you can see, it might only take you 15 minutes if you have all the information there. So like the date, what kind of request you have, if you have a deadline, put it here. Then the title, you can just copy paste, your title, brief description, your hypothesis, and so on. Then give us a name of the, probably not all investigators, just one name for the contact. That'll be good. Then your affiliation, you can choose from this list, and if your institution is not in the list, you can put it here. Email address is also required, so that's how we contact each other. All these fields these two fields are not required. You'll see there's no red asterisk here, so they're not required. If you want, you can put more extra information there. Potential meeting time is required. Just give us your schedule. If you have some documents like a draft proposal or something, just email us. Our email is here, so just email that as a attachment to your email. So normally we'll try to respond within 2 days. So if you don't hear from us within 2 days, that's very likely that's because probably there's something wrong with this Google form. So that's the best thing we can find, for this type of, forms. So we use Google form, but our experience that it's good. Most of the time, it could fail occasionally. So if you don't hear from us, just send us an email here. So basically, you submit this form, then we will get a instantaneous notification by email. Then we can access the form. Also, the research office is also able to access the form. So the research office is overseeing the research activities. So if our workload is ever going to be too heavy, the research office will decide like the priority. But for now, we'll try to accommodate every request. If you are working with a student for their scholarly project, this is another form. It's more kind of a little bit simpler. So you can ask your student to fill this out. This is our email address. Here, if you have any questions, you can just email this to us. So the intake form is required, but it doesn't mean we won't help you if you don't fill this out. We'll chase you down to make sure you will fill this out eventually, so that both the research office and us will have a record of it. So the team members, just an introduction. We have Janet Foote. Where's Janet? Oh, hi, Janet. Yeah. I'm Chengcheng Hu. We have Pao Kang there, right there. Yeah. And we have a graduate research assistant working for us like 20 hours per week. So for now we have David Margraf, but he will graduate very soon. So we have already identified a replacement for him. Occasionally we'll ask for help from other faculty members. We are all from the College of Public Health. The scope of our service, we'll provide statistical support at all stages of your project. I will go into details of every single one of this. So at the design phase, so that's the preferred time that you start contacting us. So the early we get involved, the better for us to serve. So during the study conduct, sometimes you also need statistical help. I'll mention some examples later. Of course, after data collection, study follow-up is complete, you need data analysis. So for the study, in the study design phase, this is typical things we do. There could be more for specific studies. So first, we'll review your research protocol to make sure you have good aims and hypotheses, and more importantly, you will have outcome measures to actually address those aims. That's probably the most important part in the study design. Then we can work with you to identify a proper experimental design. We'll do sample size and power analysis. We will provide a data monitoring plan if needed. So a lot of studies don't need this. Statistical analysis plan. So as you might have heard, for most research projects, it's a preferred way to conduct the research if we have all statistical analysis determined before you even enroll your first patient, before you take a look at the data. So we'll try to have an analysis plan ready at the design phase. Then of course we can always modify that later. Randomization procedure, if your study is a randomized one, will provide advice on database design. So we don't have data manager. So we're all statisticians or epidemiologists. So we don't provide database data management service, but we definitely will be able to help you to work with your data manager on that. We'll review the data collection forms to make sure everything you need is collected. Also, they are collected in a manner that's easy for us to do analysis later. So, for example, we'll try to avoid as much narratives, free text as possible. For grant proposals or IRB submissions and so on, so we'll help you draft the section on statistical considerations that will include all these statistical issues. So we'll help you draft that section. I'll just briefly go through some of this items. So I've just briefly gone through. So experimental design. So there's some examples of the elements in example design. There's much more. So we can talk about that. You might already have an idea before you come to see us. So we'll work with you to make sure that will be a good one. Sample size determination, that's probably the most important statistical work in the design phase. So you will need some kind of justification. So basically the sample size depends on first the type of objective you are proposing. So if you are trying to test a hypothesis, so for example, you want to see if a treatment is better than another or a placebo, then we're conducting a statistical test. Then here the power will be dependent on the chance. It's basically defined as the chance that will be able to detect a treatment effect if it exists. So a treatment effect of a certain size. So if your objective is actually to estimate something, say you want to estimate the survival rate within a certain population and something like that, so you want to estimate a parameter, then the sample size will depend on the precision required for the estimate. So the more data we collect, the more accurate, the more precise the final estimator will be. Just a brief review of the statistical hypothesis testing process. So first, you need to state your research hypothesis. So the thing you want to prove to be true. So we call that research or alternative hypothesis. So for example, you want to prove like a drug has a certain effect, beneficial effect compared to a placebo. Then we state the null hypothesis, so there's no drug effect. So we want to basically collect enough evidence to reject the null hypothesis, to prove the research hypothesis. Then we want to identify a test statistic, which is basically something we can calculate from your data. So this will depend on the outcome measure you identify. So we'll talk about that when we meet for individual projects. So basically this test statistics, we need that to be calculated from the data, and we need to know that like a certain we have enough information to assume like a distribution for that statistic. Then we calculate p-value. Remember that this is definition of p-value. So p-value is the probability that if the null hypothesis is true, so if the drug has no effect, the probability we will able to see an effect in the data with size of the effect as large as or even larger than what you have actually observed in your data. So that's the basically that's the probability. If the drug is not effective, the probability that we will see effect of your data from your data. So that the effect we see in your data is due to chance, due to random noise. So we calculate the p-value, then if the p-value is smaller than a pre-specified level, significance level, normally we set that as 0.5, then we know that what in our effect you observe is unlikely due to chance. Probability is it happens due to chance. Is smaller than 0.5. So we will declare, we can reject the null hypothesis. So the research hypothesis is true with strong evidence. So the power is the probability that a effect of a certain size. So we need to know the size of the effect you are expecting. So effect of a certain size can be detected to reject the null hypothesis, to conclude the alternative hypothesis is true. So as you can imagine, if the effect you are looking for, you are expecting is large, then we will need relatively a small sample size. Also, the power also depends on the variability of your outcome measures. So if the variability is large, so that when the noise level is high, then it's harder for us to detect a signal, a true drug effect there. So the larger the variability is, the larger the sample size will be required. So for the same effect size, if we fix the effect size, then smaller variability, so more accurate measure of the outcome variable will lead to higher power, and hence would require a smaller sample size. So you can imagine for the sample size calculation, what we will need from you is the expected effect size. Also some variability measures of that. So you can obtain that information sometimes from the literature for papers published on similar matters. It doesn't need to be exactly the same, say same drug, same disease, same conditions. So imagine if you already know what the effect size is, then you don't need to do the research, right? So we just need to get a sense of what kind of effect we are looking for, we're expecting. So if no prior information is available from the literature search, you can first conduct a pilot study, so just enroll 5 patients, 10 patients to get a feel of the magnitude of the effect you are expecting. So in general, a very rough guesstimate is good enough, or you can just give us a range. So a range for the effect size, a range for the variability, that would be sufficient. As I said, you don't need to know them exactly, because if you know them, you don't need to do the product. So this effect size used in power analysis, that should be realistic. So we cannot just power analysis for a effect size that's too high, so too much to expect. Also, the effect size should also be what they call clinically significant, so that it has nothing to do with statistically significant result. So this basically means the change in that effect size is kind of substantial, is kind of significant to reflect different status in the patient. So just a example, if you power, you don't expect huge effect of your drug. So you say, for example, our outcome measure is systolic blood pressure. You power your study for a 3 millimeter mercury difference. That is really too small. We can get that kind of day-to-day variation from the same patient. So that effect size is not really clinically significant. So that's some kind of preliminary information we will need from you to work with the power. So you can't just come to us and say, do a study like this. What's the power? What's the sample size? We do need some preliminary information. They do not need to be precise. It's impossible to have precise information, but we do need some information on that. So normally sample size is based on, say, the number of participants. That will give us at least 80% power, and preferably 90% power for the most likely effect size and level of variability. So for NIH grounds, 90% power is definitely a big plus. So after the sample size is determined, we tell you need 50 patients, for example. Remember that sample size is based on the most likely level of the effect size and variability. But we know you don't know those information precisely, so you might have a range for that. So we do need a power analysis, basically telling us different scenarios when you're expected, when your effect size, the true effect size, is different from the most likely assumed one here, then what the power will be. So this is like a worst scenario analysis. So we see even when both your effect size and the variability work against you, at worst, you'll still have, say, 68% of power. That's not good, but that's kind of okay, for the worst case scenario. So that's the sample size determination, the power analysis. They are related, but they're not exactly the same thing. So we need a kind of a rough idea what you are looking at. So you do need some information. For estimation problems, say your primary objective of the study is not to test a hypothesis, not to compare different subgroups. You're trying to estimate a certain parameter, a mean level, survival rate, whatever. We're estimating a parameter. Then the sample size will be based on the precision of the estimation. Say precision of an estimator is normally measured by, say, a 95% confidence interval. So basically, if we increase the sample size, we'll be able to shrink the confidence interval. Remember, the confidence interval means that we don't know the true parameter. We estimate the value of it. The estimator is probably the most likely value, but we're sure. Okay, we're 95% sure this interval will cover the true value of the parameter. So a lot of times we need, when you estimate something, you need to give both a estimator and also a confidence interval. We want to make the confidence interval as narrow as possible, so that means our estimate will be as precise as possible. So if your primary goal is to estimate a certain parameter, then we want to power the analysis. We want to have a sample size that will give us a narrow confidence interval. For example, it can be measured by the width, just simply the width of the confidence interval. So you want to say you want to estimate a certain disease rate in a population. So you expect probably the rate is 30%. you want the precision to be plus minus 5%. Then so you would need your confidence interval to have width of, say, at most 10%. That's a precision requirement for your estimator. Will calculate the sample size that will give you that kind of precision. So again the true parameter value and its variability, again, that will affect the width of the confidence interval, the precision. So again, we probably also need to do some analysis under different scenarios. We'll try more. I ask just like in the testing situation. So we calculate one sample size. That's the number of patients you will need. Then we'll calculate, say, the worst scenario. So everything works against you. What kind of precision we are looking at? So just like the other situation, we do need some rough idea about your sample, about your effect size. How much of a effect, how much of the parameter, what kind of parameter you're looking at. So you do expect that to be in the neighborhood of 10% or 50% or something like that. So kind of rough estimate. You can again get those information from either literature review or a pilot study. So we'll develop a analysis plan. So a lot of times it's also required by the IRB, because of course it will be required by funding agencies. So typically in a analysis plan, we'll basically we'll have kind of some standard language. So what kind of descriptive analysis we're going to do. If we are trying to compare certain parameter across different subgroups, we'll mention what test we are going to use. If we are going to estimate and test certain association, we'll state what kind of model we'll use. And if you are also interested in a prediction problem, so you want to build a model, say to predict, say for example, the 10-year hip fracture rate for elderly women. So your model will be applied to future patients. Then we'll have a plan. So what kind of procedures we will take to build such models. So that's the analysis plan. We also provide advice on database management. So probably there will be a lot of work before the study starts. So we identify all these variables. Will help you or your data manager in the development of the data collection forms. So we help you design the database and put in some quality control procedures, and also there should be some procedure for kind of routine operational reporting, like the completeness of your data. So up to now, each clinical report form, the data completeness is 70%, 80%. You would need to know that on a periodic basis to basically monitor the conduct of the study. So we hope to have such a plan in place. Also, there should be procedures ready to produce data set to be used for data analysis and data security. That's also a concern. So we'll provide advice for you. So we are not able to actually manage the data for you. So we don't have a data manager on board. So this is mainly a statistical service. When the study is in progress, so that you might need some routine monitoring, as I said, accrual. So whether accrual is too slow, is slowing down, something like that. Randomization procedures, you might want to also look at that. Completeness of the data, and sometimes you need toxicity monitoring. So For some highly toxic studies, you want to have a periodic report of adverse events. So again, we can help you set up, this procedure so we can provide advice, but we're not able to do it. Interim analysis, that's statistical analysis we can work on, so we'll help you with that. Typically, there will be analysis for safety, for efficacy, and also for futility. So whether you still have enough chance to detect what you want to detect, given you have already got this much data. If not, if you don't have a lot of chance, you probably just stop there to save time and resources. So that's the futility analysis. So we will perform this analysis if needed. After the data collection is complete, so there will be data quality issues. So you and your data manager will try to clean the data as much as possible. Then during the data analysis, we might we almost always identify additional issues. So we'll get in touch with you to talk about, might need to send queries to the clinic and so on. We'll do the data analysis. We can prepare certain parts of your manuscript, for example, the statistical method section and also part of the results section, including those tables and figures. So we'll work together on that. We can also help you interpret the results of the analysis. We do prefer that you contact us as early as possible if you envision that you will need statistical help in the future. Just get in touch with us as an initial meeting with us at the beginning. Then if you haven't done that, then you probably need to contact us before you submit your proposal to funding agencies or to IRB. So a lot of IRBs, if they see you do need statistical expertise and you don't have that part in the proposal, they will let you know. So basically try to contact us before you submit proposals if you haven't done so yet. Before you start data collection, you can get in touch with us when you are monitoring your study and when you are preparing to analyze the data. So if you only contact us at the latest stage, then we can do whatever we can to help you. But as you can imagine, there could be certain issues like certain variables are not collected or not collected in a consistent fashion and so on. So there could be issues you're not able to predict at the beginning. So we strongly recommend that you get in touch with us as early as possible. But any of the time, we can provide help. When say in your design phase, when you come to us, you would need to have some kind of information, to give us. So the overall research question, then the target population, the specific aims. So quite sometimes we find that specific aims and overall research question, they are not that close to each other. Outcome measures, are you able to collect data that can address your aims? That's a very important thing. So you might have a big idea, but you want to make sure you will have data to check that, to answer that question. The approach you're going to take, you plan to take. So hopefully you will have some kind of effect size and variability information. And timeline. So if you have a deadline for your proposal, let us know. So if you don't have all of the information, it's okay. We can meet first, and we can identify the extra information we will definitely need from you. So don't hesitate to contact us if you do not have everything. This is just our wish list. What we expect from you, so statisticians and epidemiologists do need to be on your paper as co-authors. So as long as we provide sensible contribution, intellectual contribution, we do expect to be a co-author. So I met more than one investigator in the past who was really surprised when I asked, I should be a co-author. I did all the analysis. They were really surprised. So that's the kind of what we expect. And if your paper, the data analysis is the major part of your paper, and we do all the analysis, and we draft your statistical method section, we expect, in general, to be the second author. So there could be other possibilities. We can talk in individual cases. That's just our general expectation. If we just provide some help, which is not the major part, we do also need to be a co-author. If you need our help in preparing a grant proposal, we do expect you to include one of us in your grant at a certain effort level. So, for a larger grant like R1, R21, we definitely need a percentage effort. For smaller grant like R03 and the foundation grants, you can just include a certain amount, dollar amount for us if your budget allows. So we don't really push on it for smaller grant. For K grant, normally we don't ask for any salary support. So. But for larger grant, we do need a effort level included. Also, basically, if you ever get our support at the end of your project, please do notify us. If there's any presentation, poster, paper, any product that come out of, partially out of our work, then just let us know. So that's just a kind of a general overview of our service. So Dr. Foote will get into more details.
About biostatistics and the study design services. And again, we do have epidemiologists, biostatisticians. We also have students, and these students are able to help with the scholarly projects. When you asked about the analysis tools we have Stata, which is very easy because there's not a lot of program language that students have to learn. And so these students will actually help walk them through so that the students can do their own analysis on the scholarly project. So it's really good to get us involved so that they can do that and have things set up right. Again, how to find us. If you can get to the College of Medicine main page, you can find us. You just hit that research tab. From the research tab, you go into the resources, and then under resources, we're biostatistics and study design services, and that takes you to the page. From there are separate intake forms for a student project versus a faculty project. I mean, we know we all want to get our things done as quickly as possible, but sometimes students are on a certain set schedule and may be behind the 8 ball on things, so we really try to get access for them very quickly. So what should you expect? When should you contact us? As soon as you're starting to design your protocol, prior to submitting proposals or routing, before you pilot your survey or start data collection, and as you're preparing to start to analyze your data. And the idea is there's a lot of different ways you can go, and we're really here to help all along the process. That's what we're here for. So Chengcheng went through most of this. What information do you need to have? Overall questions. I'm going to skip through this since he went through it. And I'm just going to remind you now of some of the very, very basics. You've all heard this before, but you probably haven't thought about it, of what you need to think about when you're thinking about your studies and your study designs. So the first of all is a research question. Science is about taking an organized, methodological approach to examining a question. So the first thing we need to do is ask a question. But even when we start asking that question, we really should do a thorough review of the research that's out there. Look at the literature, because a lot of times in doing so, you often find that you change your research question. Your hypothesis may alter a little bit because you find that someone else has done something else new, and that changes what your idea is going to be. So once we get that research question and we feel that we have the formulation that we need to construct a hypothesis. And a hypothesis is an educated idea about how things will work. So there's a set way to state it. There's, if I do this, then this will happen. So we have our independent variable, and then we have our dependent variable. You want something that's testable. So for examples, if I test the blood sugar of 100 adults, more than 20% will be at risk for diabetes. And you have to define that risk. What does that risk mean? Whose scales? What, it has to be very specific. If I add methotrexate to HLA cells, I said one, the cells will stop multiplying and the cancer can't progress. I don't just say, if I add methotrexate to HLA cells, I'm going to look at the effect. You have to state what effect you're expecting. So they need to be measurable, something we can do, something we can test, something we can quantitate. So once you have your hypothesis, you test it. And it's not a one and done thing. I mean, a lot of times we're only doing one step, but again, science and advancing science is about doing something that can be repeated, and you find over and over again you get consistent results. Statistics help us understand what the odds are that the results we see are real based on our study design. And that's really important because statistics help understand the odds that our results are real. Our statistics are dependent on the type and characteristics of the data that we use. So your statistical test may be different than someone else's because of what kind of data you used to get at that answer. Statistics cannot fix design or data or recruitment problems. We'll help you deal with them the best that we can, but it can't fix something. It can't make your data look better. I mean, once you've gotten that data, that's the data you have. And all we're doing is helping that data talk. So you can't fix things as an after effect, and that's why we really want you to get us involved in the beginning. So what is data? We talk about this a lot, and again, this is going to be a review, but we don't think about it on a day-to-day basis. So data are those values. It's our pieces of information. It can be categorical. It can be a quantity. It can be nominal or ordinal as far as different categories. Binary, discrete, or continuous. There can be different qualitative or quantitative characteristics of the data. So categorical data is something where it's grouped into categories. Makes sense. So these categories are just labels. It could or could not have some kind of underlying structure. So if it's an unordered category, like types of bicycles, types of newspapers, things like ethnicity, which is a really, really messy variable, but we need it in almost everything, it falls into unordered categories. So that's considered nominal data. If order is important, such as the highest level of education or degree of illness or something like that, then it's considered ordinal data. So our test may be different for ordinal data versus nominal data. Binary data is very specific, where you only have two possible outcomes. So it's either this or that, class mark, pass or fail. Current smoking status, where you're dividing it into two groups. Currently, they're either a non-smoker or a smoker. So this just gives you an idea that even when you think of categorical data, there can be different types in that categorical data, and these are treated differently in statistics. Quantitative data, again, it's something that's measured. So So it's a set of numbers. So pulse rate, height, age, those types of things, exam marks. Quantitative data can also have different classifications. It can be discrete or it can be continuous. And in discrete data, we're talking about something that only has certain values. You have 2 kids or you have 5 kids. You don't have 2.4 kids, that type of thing. Or it can be continuous. So the quantity is continuous where you're measuring something, and if you could have a measurement tool that made it precise enough, there would be no gaps in that data. So if you were, again, discrete data is things like children in a family, crimes reported in a day, bicycles sold in a day, so they're counts. Whereas continuous data, it's something that if you could measure close enough, there would be no gaps in that. And if you looked at how those looked, discrete data is you're getting whole numbers, whereas continuous data, there's no gaps. And how you treat those statistically is different. So it's important for us to know what kind of data you're getting, because that's going to vary what statistical test you use. So again, why is this important? Because the type of data collected determines the type of statistical analysis. So how do we organize all that data? We put it in a database. And our database is just our method of organizing and analyzing the information. There's a lot of different ways to do that, but I want to emphasize that there are better ways to do it and there are worse ways to do it. So it helps to get in touch with us so we can help you set up something that's going to work the best for you. This could be a whole talk in itself, but I'll say it up front. Excel is not a database. It was made to help people with financial spreadsheets. If you're doing a very small study, especially a lot of the scholarly projects, yes, you can use Excel and we'll help you with it, and there are things you can do with it, but it's not ideal for many, many reasons. It really wasn't designed to manipulate data. It wasn't designed to keep controls on things and make sure you have the right outcomes. So, you can use it, but it's not ideal, and will help if you're doing, especially if you're doing larger studies. We would really like to recommend some other tools that would help. Again, this is a little bit more, and I'm just putting it there because that's going to be there for people to read on the website. There are resources. Yes?
I was going to say, what would you recommend? What's a simple tool would you recommend for a database? I know it varies, but...
Things like Microsoft Access, but we have 2 tools that are available to us that the University of Arizona has licensed for our use. Qualtrics, which is like SurveyMonkey on steroids, so it's freely available. It's easy to use for students or if you're doing a survey. And RedCap, which is something that they licensed about a year ago. It can be used for clinical databases and getting the data in the shape. The advantage of these are the back end is developing a database. So you're making controls. The data you're collecting is already controlled and being put into a database in a format that's going to be usable. So it really helps. You don't, Excel, you can, especially if you make a long line of something, you can easily get your rows askew. And then suddenly people are putting in things and they want to sort something and they didn't grab everything. So they only sorted half of the observations and the other half aren't sorted, and it gets to be a mess in a hurry. So these are freely available through the University of Arizona. So it's just signing up for a license as far as that goes. So those are 2 that we would recommend. So how's the database organized? It can be one big table. It can be multiple tables. Usually there's some kind of patient identifier. A lot of times you want to keep demographic, very specific information separately and just use patient identifiers so you don't have all the confidential information problems and things like that. So getting into fields and records, we usually think of fields as our variables across the top if you think of a nice flat file, and our records are different observations or different cases. So there's different ways you can do this. You can do everything in one big file, or you can use something like relational databases where you see something like ID is used in several different tables, and then you're putting those tables together. And typically, you're having someone who is your IT person pulling those tables together, especially if you're doing something using medical records. An IT person is usually a little bit different than a data manager. And this can be a whole nother talk of what we need as far as doing electronic medical record research. Electronic medical records are going to make it really, they're going to facilitate some of the things we can look at, but they're not ideal in some ways because we don't always have all the parameters we want. When we go back to that variable ethnicity, well, who filled that in? What were their options? You know, a lot of times you're getting the physician or someone else filling in that ethnicity parameter, and that may or may not be accurate. So we need to think about some of those things, and hopefully with the service now, the Biostatistics and Design service, somewhere down the line we can kind of help formulate what's needed to do more electronic medical record research out in the community and help get some of those things together. So a clinical research, a clinical database, you're usually reporting something for the benefit of the patient and the doctor to try to discern a condition or something like that. Whereas a research database, you're really orienting the data so that you can look at the whole group together and try to find consistencies or variations. So you're not really looking at individual records, you're looking at a group of records. So in a clinical data, you might have something like an outcome from a metabolic test, whereas in a research database, you're doing the outcome of many of those tests. So it does look a little different, and you want to compile it a little bit differently to make it useful and more easy to analyze. So the advantages of a database are that it can collect data into a centralized location. You can help control redundant data. It drives me nuts when I'm filling out questionnaires and they ask, you know, your age 14 different ways. You know, what year were you born? What age group do you belong in? You know, what is your current age in years only? You only need to ask that once, and you only need to get it to the specificity of what helps for what the outcome will be. You know, if you're going to look at people in age ranges, you don't need to ask them their exact birthday. So it's those types of things that you need to think about, especially when you go to IRB, because something like a birth date is much more invasive in our eyes, compared to something about asking people to check an age range. So it's those types of little things that you want to control. You want to not be asking 5 questions when you could do 1 question that would give you all the data that you would need. Data can be stored so that one location has the data, and you don't, you know, everyone can work on entering data at the same time rather than having an incomplete set of data at 2 or 3 locations. So multiple users can use the same database. And it allows access to be controlled. It allows checks on who's accessing that database, all those types of things. So that's why we recommend a true database utility rather than using something like Excel. So what to collect? You want to make sure that you collect the information you need for the question that's being asked. So you want to think about what your data tables are going to look like in future publications. And that's where we get back to what demographic data do you need to start out your study? That's usually the first table in every publication is the demographics of the population. What's going to be important? What do you need to know? And you also need to think about what statistical package you may be using, because typically you're going to format the data in a way that can be used more easily by the statistical package. What characters are allowed? I've seen students who have named their spreadsheet in Excel with using different characters in it, Y23 question mark or something, and suddenly they can't read their database into a statistical program. And it's not because it's not formatted well, it's because the statistical program isn't recognizing those characters. It may not want a space in something, or it may not want a hypothesis or something like that. So you just have to be aware of what the program likes and what it doesn't like, and what characters may be an issue. So there are different ways you can set things up, like a long format or a wide format. Long, we're talking about a different row, if you want to call it, or a different case for each year someone is seeing, where you can do those same things by just using headers that have the information for the year. So you can do it either way. It's just one way may be more easy to manipulate for whoever is doing the statistical analysis. So some of the things you need to think about when you're thinking about planning your database and planning your research is you should only collect the data that you actually need. This goes back to IRB. The more invasive, which means the more questions you ask, the more you do, the more you have to be responsible for. It also just is more effort and time on your part and your staff's part to keep track of all that. You want to make sure you have good hardware and software. You want to plan out the analysis with dummy variables. Your students, or you can have all your programs basically planned before you even start collecting the data if you have this set up in advance. We hear people, well, I didn't get the data until yesterday, so I can't give you a preliminary report. Well, if you had worked it out with dummy variables, once you have the data, you can run it. You're set. And if you're developing study forms, you want to make sure that you understand how different variables are going to be coded, how to format the different boxes for data entry, what you're going to label. So if you had to go back and find something, okay, question 8 is located on table 2, question 5, or something like that. So what needs to be in the database? The research variables that are directly related to the hypothesis being tested. Clinical measures, it may or may not be important depending on what you're looking at and how important that clinical measure is there. Administrative data, like did they show up for their appointment, that type of thing on June 21st, that's not part of your analysis. That doesn't need to be in your research database. So keep your research database specific to the information you need to do the analysis. So your original data is your source documents. That's the first recording of everything. It tells you what you did, when it was done, whether the study was done according to protocol. Examples of source documents are like your original lab reports, pathology reports, films, letters, medical record, that type of stuff. And common data elements, you want to make sure that you use standardized, unique terms and phrases that give you information about those specific things that you're collecting. Uniform, again, you hear these consistent words. You want to make sure it's something that everyone understands in the same way. So you want to make sure that typically you have more than one way of quantitating your endpoint, just to make sure there's an added check, that you can look at it this way, you can look at it that way, and it's the same endpoint. You want to let the data speak. You're not recording someone's idea of what happened. You're recording the actual data, and then you're going to do the analysis and let the data speak for itself. It's not interpreting at this stage. It's just a database that's collecting the information. Again, there are different data types that have stronger statistical power, so that's why you get in touch with us, so we can help you get those, collect the data that's going to have more statistical power. You can always analyze it in several different ways depending on what kind of data you've collected. If at all possible, use validated measures or validated scales or instruments, because validating a scale or an instrument is in itself research, and it's fairly time consuming. You want to collect key variables more than one way if possible. And you want to avoid measurements that are going to be all at one end of the scale, because then it's really hard to discern differences. We can help you design forms, and again, that's just some of these. Sometimes you don't have options if you're doing electronic medical research, but again, you may need to augment what's in the EMR in order to get all the information you need for your study. When you do a study, there should be an operations manual. It doesn't have to be, 3 inches thick. It can be something that's fairly quick, but it helps to make sure that everyone's on the same page. They have something to go back to if they're afraid to ask. You should have the entire study protocol there, what the sequence of events is. You should have a figure for it so they can easily look. Make sure there's annotations about if a form changed, that kind of thing. You want to periodically update it if things have changed, and you want to use it in training of any new staff, in quality control, and in planning for the future, and actually doing your analysis. A data dictionary should also always be included with the database, and that gives the variable name, what the description is in plain English. If you said, it's sex and it's participant self-reported sex. Be specific, because that's what someone's going to come back to when they look at this data file and say, what is this? What does this variable mean? Where did it come from? How did they code it? So you want to know whether it's a character variable or whether it's a number variable or a date. How long it is, as far as, does it have 3 characters? Does it have 5 characters? If it's supposed to have 5 characters and you come across something with 3 characters, there's a problem. And this data dictionary will help you know right off the bat that it's a problem. What do you do with a value that's missing? A 0 is not the same as a missing value. So if someone says, if you ask how many children you've had and they don't answer, it's a no answer. But if you ask how many children they had and they say 0, they have not had children, and you know they have not had children. And these are those things that databases can help you do, because if they're filling it in on their own, it can be something where they don't go on to the next question unless they respond to that. So you know right away that they had to respond to that. So they either had to put in the 0 or they quit the study at that point. So it's those types of things, but it's really important to differentiate between something that is a missing value and something that may be a 0 or doesn't pertain. And it gets into these things, knowing your family history. Well, if someone was a foster child, they may not know their family history on certain diseases and things like that. So you may want a variable that says don't know. So think about those types of things when you're designing databases. This is one example, and it's a not very good example, but it still gives you an idea of what a data dictionary does. So you have something like any skin cancer. The code was either yes, 1 is a yes, 0 is a no, and what the variable meant when it was collected. Why do we code? Because it forces us to give data that can be analyzed, correctly formatted so we can do our statistics. It simplifies the analysis. It speeds data input. When you're trying to look at yes and no, when you get to the statistical standpoint, you have to code that variable because your program wants to see a number. It doesn't want to see a word. So it helps a lot to have how you're going to format it and have that done before you get to the analysis part. And here's another example for the need for data coding. If you just ask someone's subject, their sex, this is what you get as an answer, and suddenly you have 20 different responses for sex. And someone has to go in and clean that all up. So it's much better if you, well, here's another example. Headache. Do you record it as pain in the head, as a headache, as an ache, a specific kind of ache, which is a head? You know, those types of things. You can get different things if you don't ask your question well. So unless there's a standard code to use for terms, it can make it very difficult to get everything together to analyze. So each variable should have its own field in a data set. Categorical or nominal variables will require a number or a string code in the end. You can put continuous variables in directly. Missing values should be differentiated. You need to use something different, like a 99 or a -8 or something like that, so they know it's missing and not something that was part of your data set, you know, that it was a response. The coding instructions should be very clear. You should have a data dictionary, and if at all possible, avoid open-ended questions. And these would be your example of open-ended questions, and much better to do something where it's like fill in the box, and then you get a very specific response. So by using a database with pre-coded responses, if someone puts it in, well, this is something you can get in a data sheet, and you can see that with open-ended questions, people, you know, ask things a little bit differently, or they spelled things wrong, and you suddenly can't categorize that. But if you're using a database, when something goes in, it usually tells you, oh, you just gave me a 3-digit number and it has to be a 4-digit number. So you build something that has those controls so you don't have to worry as much with cleaning up the data on the out end. So there's different kinds of editing checks as far as making sure things are correct, whether it's missing data, whether it's consistent, whether the ranges are appropriate. With a database, you can easily back it up and make sure it's protected. That's very important. So putting it all together for data management for research, it's a selection of physical and electronic management methods. We don't use paper forms very often anymore, but we still want to make sure that the databases that we use, and we think about those little pieces of information when we start so that we're getting something that can be analyzed on the back end. So attention to detail, very specific structure and process to everything you do, having it well documented are all the attributes of successful data management. So as far as data goes, fast is fine, but accuracy is everything. So we really want to emphasize quality. A little bit on study designs. As Chengcheng went through, there's different types of designs. How you can interpret the measure of association varies depending on how you designed your study. So there's different, you know, what data you got, how you approached it means you can come to a different conclusion. So it's important that all that be in sync when you're going to start the process so that you come out with the type of conclusion that you want. So we want to be thorough, but again, we also want to be as minimally invasive as possible when we're doing research. And that gets to where you are now, which, you know, we get these surveys that take forever and ever, and he's saying, shouldn't take much longer. Could you just confirm the maiden name of your mother's uncle's second cousin? And just that brief review, again, if you can get to our main page, hopefully you can find us under resources and then biostatistics and study design, and then find our actual page. And hopefully we can get this kind of streamlined a little bit in the future. And that's it.